Excellent. Yes, so thank you. So today we'll talk about modeling malaria elimination. You may have had some talks on malaria, but in case not, I'll give just a very brief introduction to malaria first, and then talk about the models we use, how we build it, and how we use them in the particular case of Zanzibar. So malaria is a very, very old disease. It's probably been with humans for as long as humans have been humans. So it's really evolved with us. There is sort of this picture that you see here is the Zebras papyrus. This was discovered in Luxor in the 19th century, and it's a text that goes back 3,500 years describing the symptoms of malaria, and it's thought, and it's expected that there are written tests describing malaria going back over 5,000 years. So it's really been with us for a very long time. As you know, Nigeria is the country with the highest burden of malaria. It is a disease that causes symptoms that can range from relatively mild fever to severe anemia, coma, and death. And it kills hundreds of thousands of people, mostly children, every year. It's an environmental challenge. It is a cause of poverty, but it's also a consequence of poverty. So it reduces GDP growth, and places that are poor are more likely to have malaria because it is a disease that we can treat well and that we can control well if we have enough resources. And it's been a major force in history, leading to changes in wars, and it had a huge effect in World War II, where a lot of the fighting in the Pacific was over control of quinine plantations that were used for controlling malaria. And there were many battles where more people died of malaria than actual fighting. It played a role in colonialism in Africa, in preventing colonialism. It played a role also in the fall of the Roman Empire. So it's been a part of humanity for as long as we've been humans. And now to modeling. So the first ordinary differential equation for any disease was published by Ronald first in 1910 and then in 1911. And here you can see the equations, which are still the same kinds of equations we use today when we talk about malaria models, or often now called the Ross-Macdonald model. So Ronald Ross was the first person first of all, he demonstrated mosquitoes' role in transmission. So before him, the mosquito was not identified as the host of malaria. Ronald Ross did it for bird malaria, and this was later followed by someone else showing that mosquitoes were responsible also for human malaria. And Ronald Ross is known for developing the first model for malaria. And what he was able to do with this model was to calculate a basic reproductive number, which we now know as the number of new infections you get from one infectious case. And what Ronald Ross showed with this model was that you'd not need to get rid of all mosquitoes to get rid of malaria, but you just need to get the number of mosquitoes or the density of mosquitoes below a threshold, where R naught goes below 1, to eliminate malaria. And this led to a lot of work in the early 20th century where malaria control focused on larviciding. So it was really about draining ditches or draining ponds where water collected, cutting brush and vegetation around where water would have collected. And then in breeding sites which could not be removed, it was using oil and other larvicides to kill larvae. And a lot of this work had, again, in many places worked very well, sometimes not great. And it's really this work with larval control that enabled the building of the Panama Canal, where a combination of malaria and yellow fever made it very difficult to actually build a canal in the late 19th, early 20th century. And then just around the time of World War II, so quinine was synthesized by Bayer AG in Germany, used as a substitute for, chloroquine was synthesized, used as a substitute for quinine, because quinine had been known for centuries. Quinine has worked very well against malaria, but quinine also had substantial side effects. And chloroquine, as you can see from the chemical diagrams, is similar to quinine, but has a chloride over here, and this bit is different. It was initially stalled because it was considered too toxic for human use, but then it turned out that it's actually not. So it does have side effects, but it's not as dangerous as previously thought, and far less dangerous than quinine. So around the mid-20th century, we had very good treatment for malaria. We also then around the same time discovered DDT. This was done sort of close to Basel, where I'm currently now. And what they found out was that DDT was a fantastic tool for killing mosquitoes, for repelling mosquitoes, for preventing mosquitoes from entering houses. And then George Macdonald came and he took the model that Ronald Ross had developed. He tried to calibrate this model to epidemiological data. He tried to estimate how long people are infectious, how long it takes mosquitoes to become infectious. And what he showed with some relatively simple mathematics, P here is the daily survival probability of a mosquito. And this term here is the expected number of bites that a mosquito who gets infected with malaria would have after it's infectious. So it's looking this P to the 12. So is the probability that a mosquito survives 12 days to become infectious after it's infected. And then it's this is the mortality rate of mosquitoes. So it's looking at how many bites you would then expect a mosquito to have. And what you can see is that as the mortality rate reduces, the number of infectious bites, expected infectious bites, decreases very, very quickly. And through this relatively simple mathematics, Macdonald showed that it's much more effective to kill adult mosquitoes than it is to kill larvae and only decrease the number of mosquitoes. So this really pushed malaria control then in the second half of the 20th century from larval control to adult mosquito control. And this coincided also very nicely with DDT having been synthesized and people then having a very good tool for controlling malaria. And then if we move a little bit into the history of malaria control, this is the number of cases in the USA. And you can see around the end of World War II, there was a huge decrease in malaria. I mean, this is when DDT and chloroquine were introduced. Malaria actually went down a bit before, largely due to changes in housing, air conditioning being more widespread, and mosquitoes not able to enter houses. But it's really DDT and chloroquine that were then able to eliminate malaria from the USA. Around that time, in the mid-1950s, the world started the Global Malaria Eradication Program. So this was a way to really eradicate malaria from the world. They called it global. However, at the time, a lot of Africa was left out of this because it was considered impossible to eradicate malaria from Africa. So even though it says global, it wasn't really global. Some of the other issues with this is that this is the world, about 10 years after the end of the Second World War, where a lot of thinking was still very militaristic. And the malaria eradication program was conducted in a very militaristic fashion, where you had ideas of essentially squads, not soldiers, but malaria fighters that would go out. They would, in this case, spray houses with DDT, and they called it the attack phase, where they would try to essentially cover as many houses and as much of the surface area as they could, and do this for 5 or 6 years, and expect that at the end of these 5 or 6 years, malaria would have been eliminated, and then they would move on somewhere else. And some of the thinking here was very smart, because they realized that over time, the mosquitoes would become resistant to DDT, so continuing to spray would not work. So the idea was to really overwhelm the mosquitoes, eliminate malaria, and then stop the interventions. This worked very well in many places, but it also didn't completely eliminate malaria in many places. And here you can see examples. This is malaria cases per 1,000 people on a logarithmic scale. So at the top here, the 100 implies one essentially 1 malaria case per 10 people per year. At the bottom here, you have 1 malaria case per 100,000 people per year. And you can see in Sri Lanka how IRS brought malaria down to very, very small numbers. However, it did not go to zero, so they stopped the program and malaria cases shot up again. And you can see they went up not as high as they were in the 1940s, but still very, very high. Here you can see the parasite prevalence in Zanzibar dropping from 80% to about 5% when they halted the program, and then going back up to 60 or 70%. So in the places where malaria was not eliminated, this was called the valley of death, where malaria transmission went down substantially, and then when the programs were halted, came back again. And since then, through the 70s until the 2000s, there was not as much done for malaria control until we discovered sort of the use of insecticide-treated nets, had new interventions again, and from 2007 onwards, we've had a renewed push towards malaria elimination. The current push is much more cohesive, it's more consistent, and it's really about trying to get malaria down until we can completely eliminate malaria. And for elimination, one point to make is we tend to think of elimination as having no cases. However, malaria has a very particular definition of elimination. So the WHO classifies cases into 3 types. So you can have imported cases. So these are cases that were acquired outside where you live. So if you talk about, say, in this case, Zanzibar, these are cases that would be acquired outside Zanzibar. This could be either people that live somewhere else, get malaria and travel to Zanzibar, or Zanzibari residents who travel outside, get malaria and come back. If a mosquito bites an imported case, gets infected and infects a person in Zanzibar, so this is a locally transmitted case, but it's a first, essentially just one step removed from an imported case. These are called introduced cases. And if a mosquito bites an introduced case, gets infected and infects someone else, that would be an indigenous case. And the definition of elimination for malaria is to have 0 indigenous cases, and for at least 3 years. And after 3 years, the WHO would then certify malaria elimination, including a lot of making sure the surveillance system is strong and so on. So for countries that are eliminating, they're allowed to have imported cases, they're allowed to have introduced cases, they just cannot have any indigenous cases. So we wanted to build a model of this for Zanzibar. So Zanzibar is sort of here. Maybe before that, I'll just talk about the current elimination situation. So the countries in white, so countries that either don't have malaria or had no malaria by the year 2000. The countries in red are countries with at least 1 indigenous case. So it doesn't matter whether it's 1 indigenous case or 100 million indigenous cases. It's just they're all considered red. Countries in green are countries that have been certified by 2022. And sort of there are more updated maps which show more progress since then. And countries in yellow are countries that have had no indigenous cases for 2 years. And blue are 0 indigenous cases for over 3 years. So these are countries that are close to elimination. I think Egypt is also now certified. And here you can see a list of countries. The green countries are countries that have been certified, and blue countries are countries that have 0 indigenous cases, right, but have not yet been certified, or at least hadn't been in 2022. So again, Zanzibar are 2 islands off the coast of Tanzania. They're semi-autonomous regions that has, so they have their own malaria control program. And we wanted to build models of transmission here. You can see elimination in Zanzibar previously was, very, very high, and now it's gone down to about less than 5%, largely through good treatment, long-lasting insecticidal nets, and endoresidual spraying. And a lot of malaria in Zanzibar comes from outside, and genetic fingerprinting shows that there's very close relatedness between sort of cases in Zanzibar and mainland Tanzania, and you can see the areas of Tanzania that have been importing malaria into Zanzibar. And the current interventions are reactive case detection and indoor residual spraying. And reactive case detection is really targeting house. It's used to when you have areas with low prevalence. This is a way of targeting households with the highest prevalence. So if someone shows up at the health facility, the program then follows the person home and tests either people only in the household or some of the neighbors of this person to see if they have malaria. And if they have malaria, they're also then treated. And this is a way of sort of, if you have, as transmission goes down, you have more clustering of cases, and this is a way of catching these cases. So there's some novel interventions we considered. This included increasing the number of neighbors that we tested, presumptively treating all household neighbors and household members and neighbors. So instead of testing them, just giving them drugs. Increasing the treatment seeking rate, so trying to look at making sure more people with malaria showed up at the health facility, trying to treat imported cases and increasing vector control. We started with the simple compartmental model, so we just had an SIS model for transmission, but we had a metapopulation model where we had sort of transmission in each of the two islands and the mainland with movement between them. And this is a model where K is either 1, 2, or 3, representing the two islands or the mainland. And the transmission on any island is sort of, so the number of infected people on any island. Here it reduces when people are either treated through 5K, treated through a reactive case detection program, or where they clear the parasite either through passive case detection or just being the parasite dying out on its own. These are the new infection terms. So this is the susceptible population on any island. And here we're looking at all the ways that people can get infected. This includes getting infected. So a person from, say, Pemba can get infected either from people on the mainland or Unguja or Pemba in any of the three places. So that's why you have sort of two summation signs. So one is sort of summing over where the person is and where other people are on that place. So a person from Pemba on Pemba can get infected from visitors to Pemba, from the mainland or Unguja, or from residents of Pemba. They can get infected in Unguja from residents of Unguja or other visitors to Unguja. So we sum over all of these. We then divide the infected cases into either imported infections. So these are now, here we're only considering infections brought onto Zanzibar by residents of Zanzibar, or introduced. So these are infections either from imported cases or infected visitors to Zanzibar. So we're not considering infected visitors as imported cases, but only their onward transmission to residents, and then the indigenous cases. This has been published now, so there is an article here where you can see these equations in more detail. And again, so we have susceptible people that are infected by the imported people. They become introduced or indigenous, or they can become imported if they're traveling. Right? So again, if you take the example of Pemba residents, if someone from the Pemba residents travels to mainland Tanzania, no matter who infects this person, they will be considered imported residents on Pemba, right? So this is in mainland Tanzania. If they could get infected from either someone from Pemba, Unguja, or mainland, as long as they're on mainland Tanzania at the time, they will be considered an imported case when they go back to Pemba. If they travel to Unguja, it's again the same, no matter who infects them, because they're not in their homeland, in their home island, they will be considered an imported case. For Pemba residents on Pemba, if they're infected either from someone from Unguja or mainland Tanzania who is visiting Pemba, they would be considered an introduced case. So this is not imported, but introduced now. Or if they're infected by an imported resident of Pemba on Pemba, they would again be an imported case, right? So this is sort of one transmission away. And if they're infected if they're a Pemba resident on Pemba, and they're infected by either an introduced or an indigenous case on Pemba, they would be considered an indigenous case. So this is how we build a transmission matrix for Pemba residents, and then we would similarly do this for Unguja and the mainland. Right, and this is the full description of how they're infected. So for someone from Pemba, if they're infected on Unguja or mainland because they're outside, they would be an imported case. If they're infected from an Pemba resident who is an imported case, or from visitors from Unguja or mainland on Pemba, they would be introduced cases. And if they're infected by either introduced or indigenous cases on Pemba, there would be indigenous cases. Right? And sort of all these tables we can write into the equations here. So this is the equation for the imported case, where they're, for each of the islands, they're getting infected outside the island. This is for introduced cases, where they're either infected by visitors to the island or by imported cases of their home patch, on their home patch, or indigenous cases where they're either introduced or indigenous cases of residents on their same island where they get infected on that island. We then parameterize, I'm going to run out of time soon, so we parameterize this model to data from Zanzibar based on how many tests we had. We calibrated the transmission rate from prevalence data, and then we simulated the equations using a stochastic model. So this was a Tau-Leap adaptation of the Gillespie algorithm to capture stochastic illumination. And we know that even importation is low. Most of the cases are indigenous cases because people are infected with malaria for a very long time. We also then looked at the impact of all these interventions, and we saw that individually, each intervention had a relatively small effect. So this is the baseline. These are each of the different interventions. You can see that they don't do very much individually, except for treating almost all travelers. So if you significantly reduce importation, you can have a big effect. But if you stack all the interventions and put them together, you start to see these sort of interventions working really well. So you see this. Right. And what we see here, this is the probability of achieving elimination over 40 years. This is for different levels of treating visitors. If you do not reduce transmission, it's only if you're treating 100% of transmission that over time you will stochastically eliminate. If you have transmission reduction, you're much more likely to eliminate. So what this suggests is that you have to really stop elimination and have additional ways of reducing transmission on Zanzibar. So elimination is very difficult. And here we looked at probability of eliminating. These is saying no transmission reduction on Zanzibar, 50% and 90% transmission reduction. And the different lines show how much transmission reduction we have in mainland Tanzania. So what this is saying is that if you really want to eliminate malaria in Zanzibar, you need to reduce malaria in mainland Tanzania where malaria is coming from. So in many places that are close to elimination, the best way to achieve elimination is to help their source countries or the source areas which are sending you malaria cases. So, one example would be if South Africa were to target malaria in Mozambique, it would probably be more likely for South Africa to get to elimination. I think again, because I'm running out of time, I sort of will conclude. So again, in both these islands, it's really importation that's driving transmission, and we can reduce incidence through improving interventions, but really we need to get all these interventions together. And if we want to eliminate, we really need to target malaria in both mainland Tanzania and Zanzibar to get rid of malaria. And again, this is a relatively simple model. So we didn't consider seasonality here, either in transmission levels or in travel. We looked only at importation from Tanzania, not from other countries. And we didn't look at heterogeneity within the island, and there's probably foci transmission within the islands too. And we also didn't consider the relationship between infection and disease symptoms, right? So you can't, because with malaria, you can be infected without being infectious. And again, I want to thank all the people. Most of this work was done by Mimi Das, who's highlighted in bold. This was part of her PhD work. I thank our funders from the Gates Foundation, the Zanzibar Malaria Elimination Program, and also collaborators from Tulane. So I think that's it. I'm happy to take any questions.